Welcome to all of you who are joining us from around the world. At the last count, there were people joining us from 63 countries, and more than 400 people have registered for this webinar on putting children first in the fight against antibiotic resistance. And it's organized by the Global Antibiotic Research and Development Partnership, GARDP. Children under 5 and newborns are most at risk of drug-resistant infections, and there is very little research and development for this very vulnerable group. I am delighted to say that I am going to be exploring about what can be done with some leading health experts. After all, if we are to meet SDG 3, where every child can survive and thrive, there does need to be options for these children and newborns. We're going to discuss the challenges as well as the progress that is being made in treatments and the fight against antibiotic resistance. So it's my great pleasure to introduce to you Professor Hanan Balkri, who's the Assistant Director General for AMR from the WHO. Dr. Stefan Peterson, who's the head of the health division at UNICEF. Dr. Cristina Obiero, who is the co-investigator of the GARDP fosfomycin trial in Kilifi Hospital in Kenya, and the executive director of GARDP, Dr. Manika Balsegaram. So welcome to you all, and thank you for joining us from home, or perhaps you're at your work. We really do want to hear from you, so please do go to the Windows question area of the platform, and you can start submitting questions at any time. And it would be helpful if you know who you want to answer your question. So please do this. Without further ado, though, just to say, if you've seen, my name's Claire Dool. I'm just hosting this discussion. We're going to have some short presentations, a curated discussion, and then we're coming to the audience. So let's start straight away with Manika, who's going to tell us about why it's so important to put children under 5 and newborns as a priority in the fight against antibiotic resistance. Manika, the floor is yours.
Thank you very much, Claire, and welcome to all of you on this webinar. Thank you for joining us on this important session on antibiotics for children. And first of all, I will just give you a short introduction on what we in GARDP and our partners are doing in really the fight against antibiotic resistance, putting children first in our agenda. So why focus on children, and why have we as an organization made a decision to actually put both children and neonates as a priority for the organization? Next slide. Essentially, we have a major problem in terms of burden of disease in this situation. We have millions of newborns who suffer from sepsis every year, and sepsis and infections in newborns are a major cause of morbidity and mortality, and have a significant impact in both neonatal and under 5 mortality numbers. Next slide. Additionally, I think there is also the issue of drug-resistant infections, and particularly I think in the case of newborns. One study back in 2015 estimated between 200 to 300,000 newborn deaths. And there is a significant number of bacterial infections in newborns which are resistant to standard treatments. Essentially, there is also a lack of understanding on what are treatment options available for newborns. Currently, guidelines generally are restricted to ampicillin and gentamicin. In addition, in 2017, if we look at more globally in the issue of pediatrics and children, in 2017, only 2 out of 37 new antibiotics being developed in adults were being studied in children. Of course, when we look at younger children and newborns, that number is even smaller. So generally speaking, they are also very complex and difficult trials to undertake. but in fact, this is also what we would call a neglected population. Next slide. Therefore, GARDP actually, right from the outset, when we were created in 2016, we set up a children's antibiotic program with both a newborn and a pediatric component. And our modus operandi is largely to work through partners to develop new treatments for children and babies. Next slide. So one of our components of the program is focusing, of the children antibiotic program, is focusing on neonatal sepsis. And the program objective is really to develop treatment or treatments to replace the WHO standard of care, which is currently ampicillin gentamicin, including for empiric use where there's already potentially a high background of bacteria producing ESBL. So that's actually a scenario that is increasing worldwide, and this is, of course, a problem in many, many different parts of the world. And in effect, what we need is an alternative treatment to ampicillin gentamicin in these scenarios. Next slide. For our pediatric program, more broadly, we are trying to expedite the development of pediatric antibiotics. This can be either old or new antibiotics, and generate evidence to support treatment decisions, essentially for guidelines, but also for new adapted pediatric formulations for children of all ages. And this can include two types of study. It can include the design and conduct of regulatory studies to establish pediatric dosing and to obtain a regulatory label. But it can also include strategic trials as well for use, for guidelines and use. And in this, we have already included a project both on an old antibiotic, polymyxin B, and a new antibiotic, of which I will describe later. Next slide. And both of these components in this program are part of our 5x25 goal. And so through working through partnerships, we are intending to deliver 5 new treatments by 2025. And we hope that obviously at least 2 or more of these treatments will come for newborns or children. Next slide. So I'd like to just make a mention of our study that we have done on fosfomycin, which is really part of kind of the first component, the neonatal sepsis project that we have. We have done this project in collaboration with the Kemri Wellcome Trust Research Program in Kenya and the Center for Tropical Medicine and Global Health at Oxford, and with the Penta Foundation, as well as St. George's University and our local partners in Kenya. And we've actually recently completed a study in Kilifi, Kenya, to assess the safety and dosing of an old antibiotic, indeed, fosfomycin in newborns. There's in fact already a newborn label for fosfomycin, but there's really lack of, and this was obtained some years ago, and really a lack of clarity on what is the optimum dosing. And so with this study was really a very important study to establish safety and an appropriate dosing to treat newborns in sepsis. And I think Christina will talk a little bit more about some of the I think the challenges and lessons learned from this study. Next slide. But I think, you know, what I think would be an important message here is that there are really 2 things. First of all, we recruited around 120 patients over the course of around a year, and therefore conducted a fairly large, by this antibiotic standards, a very large trial on neonates. This was done on one site in a well-organized site, but done in a low middle income setting. And so I think a lot of work has to be done, first of all, to explain to the general population the value of the study, and of course to both the parents and the baby, the parents there, and of course that we have to conduct these studies in babies. But I think, you know, what was I think quite well done was in fact also we got really a study done in a reasonably good period of time, but also a study that was well appreciated by the population there. And I think that is actually partly also a reflection that we are dealing with an issue that is a huge unmet need as well. Next slide. So one of the aspects that we are looking at is also not just individual drugs, but combinations. And this could be combinations for neonatal sepsis, but combinations to treat infections in children as well, particularly serous bacterial infections. And for instance, we've already identified one combination of fosfomycin amikacin, which could be an alternative to ampicillin gentamicin. We are also looking at combinations of other antibiotics, old antibiotics as well. There is, for us, a sense of urgency to do this, since there is already a significant number of infections that cause neonatal sepsis that are resistant to the standard of care and the only recommended treatment in neonates. And of course, this unfortunately results in a very wide and non-evidence-based approach of different antibiotics being used in the neonatal setting. So I think it will be extremely important to generate evidence and therefore guidelines in the future for alternative treatments. So the study of both the trial that we did for neonatal sepsis, but also the large study that we've now completed on an observational study in many different countries, will help to inform the design of future clinical trials to start next year. Next slide. So I would like to make a note that we also have a serious bacterial infection program in GARDP that's focusing on accelerating the development of new new treatments for these more hospital-associated infections. And of course, I would say the neonatal and pediatric population form a subset of that. And therefore, we are kind of linking our pediatric and just our children's antibiotic program to this. And so, for instance, we have recently signed a collaboration with Venatorix Pharmaceuticals to develop a novel antibiotic, cefepime taniborbactam, to treat serious bacterial infections in adults, but also in children and newborns. And this collaboration is actually now, one of the first things this collaboration is going to do will be to expedite the pediatric program for cefepime taniborbactam, and that is actually now getting off the ground while the current phase 3 regulatory trial is ongoing for this drug combination. Next slide. So I would like to end my brief talk there, and also to thank all the supporters and funders of GARDP and all our partners worldwide who have really made all our work in this area possible. Thank you very much.
Thank you, Manika, very much. As you rightly say, some shocking statistics there about this vulnerable population, which is neglected, and certainly many unmet needs. Now, we're going to play you a video about what is being done to treat neonatal sepsis infections. The video is about 3 minutes. So just to say that if for connectivity issues, you are not able to see the video, one, you can go to the GARDP website and you'll be able to see it later, but please do bear with us. It'll be about 3 minutes. And then, just as Manika said, we're going to hear from Christina, who's actually been running these trials in Kenya. So please play the video.
Almost 2.9 million deaths are occurring within the neonatal period. A quarter of these neonatal mortalities are caused by neonatal sepsis.
There is no question that neonatal sepsis is increasing around the world. The main reason is the large number of premature babies and the emergence of new infectious agents. Obviously, a lot of research should be dedicated to prevent antibiotic resistance and to develop new antibiotics.
The last antibiotic that was produced and registered was in 1984. Trying to develop a new chemical entity involves quite a lot of work, quite a lot of money needs to be invested. We are trying to see whether we can move it to a larger clinical trial, which would be an efficacy study. We need to make sure that the infection practices within the hospitals are quite good.
To create a network among neonatologists is crucial to fight against neonatal sepsis.
We are hoping now as GARDP that if a baby now actually gets an infection, we have a treatment that actually works and we can have this baby leave the hospital as soon as possible.
Antibiotic resistant will be the main challenge of the future.
This is a waiting game. Who can wait to live waiting on you? Won't hold me down. You won't hold me down.
Well, I do hope that all of you who are joining us around the world were able to see what was a very powerful video. And I'm delighted now to bring Dr. Cristina Obiero into the discussion because, as you heard from Manika, she's been involved in the observational trials and in the fosfomycin trial. And Cristina, first of all, is going to share her experience about the fosfomycin trial. Cristina, the floor is yours.
Thank you for the introduction, Claire. So I shall briefly present on a clinical trial we recently completed at the Kilifi County Hospital in Kenya. I'll focus on the method as we are currently in the process of publication of the results. So 47% of the deaths occurring in children under the age of 5 actually happen during the first 20 days of life. And neonatal infection accounts for about 35% of the deaths occurring in developing countries and is associated with long-term neurological impairment if inadequately treated. Therefore, prompt diagnosis and management is imperative to improve survival. Empiric antimicrobials are recommended by the Kenya National Pediatric Guidelines, which are adapted from the WHO guidelines. However, liberal antimicrobial use is associated with adverse clinical outcomes beyond the selection for resistant microorganisms. Next slide. Thanks. We therefore conducted an open-label randomized control trial of fosfomycin, whereby we investigated the safety and pharmacokinetic profile of this antibiotic in neonates hospitalized with clinical sepsis at the Kilifi County Hospital. And the results from this trial are expected to feed into a larger trial investigating novel antimicrobial combinations with broader coverage against resistant microorganisms. 120 neonates were randomized and enrolled and randomized into this trial between March 2018 and February 2019. Next slide, please. So all neonates admitted to the Kilifi County Hospital were screened for eligibility at admission. And this slide illustrates the stages through which the clinical team were able to identify the patients who were enrolled into this study from the time when the child was triaged at the registration desk, whereby general study information was provided to the parent or the guardian if the child was considered to be a potential participant given the age and weight, up to the point whereby informed consent was obtained. So treatment was given priority to avoid delays, and study procedures ran parallel to routine clinical procedures. Next slide, please. KEMRI Wellcome Trust Research Program has an integrated data management system at the Kilifi County Hospital, whereby admission, clinical and laboratory data is collected and managed through an approved protocol for surveillance. And this facilitates the smooth running of research activities in the hospital. And hence, we're able to actually track the recruitment process, and in addition to that, track sample collection seamlessly. Next slide, please. So once consent was obtained from the parent or the guardian, the child was randomized to either receive standard of care antibiotics only, or standard of care antibiotics plus fosfomycin. So standard of care antibiotics in this case, as per the guidelines, comprised of ampicillin or penicillin plus gentamicin. And those children who required second-line antibiotics due to deteriorations received ceftriaxone as one of the options according to the guidelines. So neonates receiving fosfomycin antibiotic had 2 blood samples obtained after the first intravenous dose of fosfomycin and also after the first oral dose of fosfomycin. In addition to that, babies who had a lumbar puncture deferred up to the point where treatment had already been started had a cerebrospinal fluid sample collected for analysis. Next slide, please. So study procedures were followed according to protocol until termination on day 28. The main challenges we faced while conducting the study arose from the nature of our target population, which comprised of vulnerable neonates and mothers, most of whom had actually just endured labor and delivery. And also, in addition to that, you had to involve other family members who needed to be aware of our study procedures and activities. So we quickly identified and implemented strategies to optimize informed consent process and also minimize loss to follow-up. This included assessing the parents or the guardians' understanding of the study objectives and procedures, enrolling babies who were residents of the Kilifi County and who were easily traceable through the Kilifi Health and Demographic Surveillance System, and also performing home reviews for those babies who are unable to attend the 28 visits at the clinic. So we had a low loss to follow-up rate of 1.5%. Hence, we're able to have sufficient data to meet our objectives by study conclusion. Next slide, please. Thank you.
Thank you very much, Christina, and for those lessons learned about the fosfomycin trial. Could you very briefly just tell us some observations that you've made about the observational studies that have also been taking place in the Kilifi Hospital in Kenya?
Okay, so the observational study, which we call the NEOB study, is a large study that took place in 18 sites in 11 different countries. And the main objective of this study was to generate robust evidence on the etiology, clinical presentation, diagnosis, management, and outcome of neonatal sepsis in diverse settings. And so for our experience in Kilifi, we started screening and recruiting babies aged below 60 days at the same time as you are completing follow-up of the neophospho trial participants in February 2019. And we had a smooth transition from neophospho to neo-obs because it's much easier to obtain consent for study participation in an observational study compared to obtaining informed consent for study participation in an interventional trial. So one of the highlights that we experienced while conducting this observational study was identifying the first case of neonatal sepsis secondary to a carbapenem-resistant organism in rural Kilifi, where carbapenims are not commonly used. Actually, they're very rarely used because of cost issues. And on top of that, if they are prescribed, then this is guided by antibiotic susceptibility results if available. So at the Kilifi County Hospital, KEMRI has been performing surveillance for invasive bacterial infections since 1998. And therefore, that's how we are able to tell which kinds of infections we have in our setting. And so this baby who had carbapenem-resistant infection, organism-causing infection, had been referred to us, the mother had been referred to us for an emergency cesarean section from a peripheral health facility. The baby was born prematurely and subsequently had targeted antibiotics administered. And thereafter, she was discharged from the hospital after staying in for about 2 months. So this case actually illustrates the imminent threat posed by antimicrobial resistance to newborn survival in resource-poor settings.
Thank you, Christina, very much for those observations there. You've obviously been very busy in the Khalifi Hospital. Let me bring in our other health experts, Professor Hanan Balkri from the WHO, Dr. Stefan Peterson from UNICEF, and Manika, the Executive Director of GARDP. We've been hearing quite a lot about hospital infections. It's obviously a big concern. Christina, with hospital infections for newborns, what is the situation in Kenya? And very briefly, what is the government doing about it there?
So regards to hospital infections, first of all, I'd like to say that there's a paucity of data on the etiology of infection in newborns in developing countries, and particularly in Kenya. So, and most of the data is based on blood cultures, which, as you know, have a very low sensitivity rate of about 5% in our setting. And therefore, we have a lot of babies who present to us with signs and symptoms of infection, but are not able to tell exactly what's causing the illness. On top of that, we have been able to identify different pathogens causing infection using blood cultures that are done routinely in our setting, both at admission and also while in the ward, whereby you have a child who's well for a number of days and then deteriorates. So you have to investigate and try and see what could be causing the infection. So you do a blood culture alongside other investigations. And so through this, we've been able to identify infections which are acquired within the hospital. And additionally to that, identify resistant organisms, which require more sophisticated treatment regimens on top of the routine recommended antimicrobials. Another thing that we've been able to do in our setting has been to do environmental swabbing within the hospital setting. And through this, we've been able to identify different microorganisms that have contributed to infection within the hospital setting, and also the emergence and spread of resistance. Yeah.
So, Christina, of course, it's a trade-off. The government has a policy of wanting more women to deliver in hospitals, but you're seeing a rise in these infections in hospitals. Hanan, if I can bring you into the conversation, because, of course, I know that in your native Saudi Arabia, you were very involved in infection prevention control and, of course, in your position at WHO. What can be done about improving infection prevention control in the hospital setting?
Thank you very much, Claire, and welcome everybody. And I'd like to thank Manika and Christina for those great two very important presentations. And also not only my background as IPC, but I'm a pediatric infectious disease person. So I usually dealt with these very fragile babies, and it's very important that we do, I do totally agree with Manika, they are kind of considered a neglected group. Neglected when it comes to developing guidance on how to manage these babies, and also in prioritizing them while doing research. So those are two things that were very much highlighted. I think the complexity that exists around neonates, it's because they are attached to a mother before they come out. And what happens to the mother as well also affects the types of pathogens that these babies develop, specifically in the first 4 weeks of life. Specifically, if the mother develops premature rupture of membranes, which we refer to as PROM, and if they are already colonized as an adult population in a specific community with multi-drug resistance pathogens, which is becoming much more of a global problem, then you're already dealing with a neonate that is primed or exposed to these difficult pathogens. There's a lot to be said, of course, but maybe I'll just focus again on the IPC part in the healthcare setting. It has its own main challenges, and again, the variety of level of the healthcare setting and the neonatal ICU or step-down units. Babies are considered important to give them breast milk. You can imagine that sometimes the mother is sick, so she has to pump the breast milk. The breast milk has to be stored. The storage capacities, where it's happening, the contamination of the refrigerators of the artificial nipples, the isolates where the babies sit in, they need to be cleaned. There's a lot of peculiarities on the disinfection and cleaning in the neonatal areas. and in the labor rooms and among the mothers that are really important in trying to mitigating internal infections from what they're colonized with, or a spread within a unit, which becomes even a bigger disaster when you're spreading it within a specific unit. I'm sure Stefan will probably talk about hygiene and water access, so I'll leave the UNICEF aspect to him. There's a big issue to address in access to clean water. So I'll stop here. Thank you, Claire.
Thank you very much, Hanan. I mean, if we move on, and we heard this from Manika in his presentation about the fact that there is high levels of resistance to the one drug at the moment that is used to treat infections for neonatal sepsis, which is on the WHO recommended list, ampicillin gentamicin, if I pronounced it correctly. Now, I also understand that this list has not been updated for some 50 years. So could you briefly tell us why it hasn't been updated, and what are your plans to update it? What are you looking for so that you can update this list of treatments?
Thank you, Claire, for bringing that issue up. And I think this is something that's very important. And as you said, the WHO guidelines need to, it's not been 50 years, it's been a bit less than that, much less than that. But I think we need to pay attention to the issue of guideline development by the WHO. It has to be based on specific evidence, and it's basically guidelines. So the healthcare settings that already have their own, what we call antibiogram, levels of resistance within each hospital, they have to establish what is known as their own antibiotic guidelines based on local antibiograms. And as Christina clearly said, not all areas, not all places in the world have that. And that's why we have to have these global guidances to help. And this is what we're facing, a big challenge with these significant numbers of death among neonates. And I wanted to reassure the audience that we're looking very seriously into these guidelines now, and hopefully there will be major movement to updating them very soon. And updating them alone, again, is not going to be the solution if we do not make those agents available at a reasonable price to the countries so they can use them. So it's a very complex situation where we have to have the evidence, we update the guidelines, we ensure they become on the essential medicine list. Then we need to work with our partners for access to those antibiotics and at an affordable price. And one last thing is the production of them at an affordable price means that we would be pushing for generics, which means we need to be very careful about counterfeit medications and that we're really getting the appropriate medication to the child in a timely fashion. So I hope that would be one of the things that I would be successful in working with my colleagues here in WHO and our partners in establishing.
As you say, there's a number of stages that have to be gone through before you update those guidelines. Do you have any best case time frame scenario for that?
For me, it's yesterday, but we'll see how fast this goes. It's very difficult to predict, but we will try. Again, we have to do this within, I think, but there are interim things that still can happen. So again, I would leave that to maybe another discussion, but it's a very complex process and we need to work on multiple fronts to make this happen.
Understood. Well, of course, the GARDP clinical trials will, we hope, give you some evidence there. Christina, can you give us an idea? When do you think you're going to be getting the results of those trials?
So for the neophosphate trial, we're in the process of submitting and publishing the results. So we are hoping to have the results published in a peer-reviewed journal by around September this year.
Thank you, Christina, for that update. As Hanan has said, yes, it's all about, once we've got these new treatments, getting them to the people who need them, making them accessible and affordable. So let me bring you in, Stefan. Let's move forward. Let's imagine that we have got some of these combination treatments that Manika was telling us about. UNICEF's very well known for its medical supply division. How are we going to get these treatments to the people who need them? How are we going to overcome some of the bottlenecks?
Well, you know, I think a new drug is essentially like a car. It's sort of a nice thing in itself, but it needs a road to ride on to be useful, and that's obviously what we're talking about here. And the time to plan that is now. Let me raise a few points in regards to this. If we look at the current situation with COVID, I think it has alerted us to how fragile some of our global supply chains can be, because we're talking about getting a drug from the producer somewhere in the world to the right mouth and the right kid, the right newborn in this case. And when, as for many drugs, there is one or two producers of active pharmaceutical ingredients in the world, often in China, they are made into the finished drug, often in India, and then the whole world relies effectively on one or two suppliers and flying everything around by airplane. We've seen that as being a very fragile system now. And as UNICEF, as you rightly say, we buy a lot of these drugs. We do pool procurements, we procure on behalf of governments, etc. A lot of that time, it's about buying the cheapest thing at the right price. But I think the world itself has built it itself into a system which is, at one level is economically efficient, but is vulnerable. So I think going forward, we need to think about more than one producer in more than one region if you want to have supply chain security. So that's sort of one point, which might come at a slightly elevated price compared to what we're used for. So that's one thing. The second one is, of course, and having functioning markets thus. The second argument is about the supply chain once you're in the country, because you're at national medical stores, but it needs to reach that hospital, it needs to reach that clinic. And that's a huge issue and investment that goes far beyond an individual drug, where UNICEF is working with many partners to actually analyze where the bottlenecks are and remedy those. Those are investments are also going on. And I think, again, some of the attention that COVID brings out helps us, because if we're already now having 20 million kids who are under vaccinated, and we're having kids who don't get sepsis treatment, who don't get diagnosed, etc., chances are those same weaknesses will apply to the COVID system as well. So that's a huge area of investment. But where I really wanted to talk about here is that it's all and well to have a new drug, and we really want to applaud GARDP and partners for doing this for children that are so often left behind. But let's make sure that we don't waste this drug like the old ones. And that means we need rational use of these drugs. We need those treatment protocols that need to come from the kind of research that Christina and others are doing that actually tell us when is it time to switch to the new drug, how long can we stay on the old drug, etc. And that treatment, those type of studies have been rare. They need to become treatment protocols that Hanan alluded to. Then we need to train both staff for them to use it, and build incentives for that. But we also need acceptance from parents and the population at large that the pill for every ill is not the right way to go. It's only when you critically need this drug that you need it. We also need to build incentives at national level that it's not the volume of this drug you sell that is going to make the price for you. It's providing access to the right people. So there are very interesting examples now from the UK about decoupling the volume of drugs from the profits. And I think those are avenues we need to look at, so we don't really push and build an incentive that ruins this drug as well. But then I wanted to move beyond the drug and say there are other aspects that are key for preserving the drug efficacy as well. It's about reducing infection, because as long as we have delivery clinics where a midwife cannot wash her hands, which unfortunately is the case in so many places around the world, we have a quarter of the world's health facilities don't have running water. So obviously we're going to accumulate a lot of infections when we bring women in to deliver in places where a midwife cannot wash her hands. And we cannot throw good drugs at such situations. So it needs to come together with the systems intervention, such as WASH, such as actually infection prevention and control protocols. When we as UNICEF invest, for instance, now together with partners in neonatal intensive care units, it's not just the architecture, it's all of that IPC that Hanan knows so well. And then it is the behavior change aspect, because I think so far we've lived in a world where there's a pill for every ill, and the broader the spectrum, the better. And we need to change that perception in health workers, but also in parents and the general population. So we have a major education effort here. So I think there's no simple thing, Claire. It's a systems approach to this that we need to take. Thank you.
Thank you very, very much, Stefan. And I am going to go to the audience in a moment, but I'm just going to bring Hanan in there, of course, because, yeah, there's issues of access, but as you've rightly said, excessive use and changing behavior. Hanan, would you like to respond to that, or what some of the other points that Stefan has just made before I go to the audience? And Hanan, if you'd like to unmute yourself.
Okay, thank you. Thank you, Claire. Thank you, Stefan, for the great intervention. I wanted to focus and follow up on what Stefan had mentioned about the proper use of antibiotics, which seems to be very easy to those who have not delved into this topic specifically. So when we talk about using proper antibiotics and initiating antimicrobial stewardship programs, WHO has produced last year the Antimicrobial Stewardship Toolkit, which helps guide countries on how to establish these programs that are very complex, because they really have to be geared towards the country. And when I say the country, it's the country specifics, the population of the country, but also the pathogens that are lurking in the healthcare setting of that specific country. And you will not be able to find that information if you do not strengthen your lab capacity. And the lab capacity requires strong microbiologists and reusable items to be able to do the cultures and whatnot. But you also need the capacity at the bedside for those who are drawing the blood, and that they're not contaminating it, because again, you can get false contamination of blood culture. So there's a lot of complexity here about that. The antimicrobial stewardship means simply is that you provide the healthcare provider with their first, second, third choices based on pathogen, based on syndrome. So that matrix really has to be done at the hospital level, and you have to have the leadership to be able to run those programs. Last point is the complexity, again, about the IPC, the leadership on the ground, building the capacity on the ground, for specifically nurses, because they're really the backbone of the healthcare setting, on what do you need to do to prevent any type of what we call artificial interventions to a baby. What do I need to do, or for any patient for that matter? We want to put less central lines, less bladder catheters, less healthcare days of hospital stay. So the more we reduce exposure to the healthcare setting with all the glory that comes with it of lines and catheters, we're really saving those patients and babies from infections. So I'll stop here, and maybe we can catch up with some of the questions.
Absolutely, and we've got a lot of questions coming in there, and one of them is, does low birth weight, is that a factor contributing to the risk of developing sepsis? Stefan, you're nodding your head there. Would you like to come in on that one? And then perhaps Christina, who of course is really on the front line in the Kalifi Hospital. So that's a question from Humphrey Kitsio Otieno. Does low birth weight, is it a factor contributing to the risk of developing sepsis?
Totally, and Christina obviously knows this, so this is at my peril responding here. But low birth weight is a predictor, and so is not getting your breastfeeding started within the first hour, and then staying warm. So there are a number of issues in the essential newborn care around the delivery there. Not just the clean hands of the midwife, but being, and not that the baby can control it, not being low birth weight, getting the breastfeeding started, staying warm. Christina, what did I miss?
Over to you, Christina.
Actually, thanks, Stefan. You actually covered most of the risk factors for sepsis in units. And just like to agree with you that that's the bulk of the predisposing factors on the neonatal side. And you also have the other factors that are maternal, for example, maternal infections, UTI, urinary tract infections, chorioamnionitis, and if the mother has GBS infection secondary to group B streptococcus, which is very important because in developed countries, you have mothers being screened for group B streptococcal infection and being given intrapartum antimicrobials to prevent their babies from getting early onset sepsis. While in our setting, the developing countries, we don't have routine screening of mothers for this infection, and therefore antibiotics are given blindly at the setting during delivery in the hope of protecting these babies if the mother has probably maternal fever or other factors that may suggest that the child is at high risk for infection. Yeah, thank you.
Yeah, I think to be very clear, just clarify the umbilicus and the care of the cord. So important. And I think there have been major advances in that field, but still a lot to be done.
Yep. Thank you very much for Stefan for this one. And I don't know whether this is between Stefan and Christina, but there's a question about what's the prevalence of gram-positive and gram-negative infection in neonates. Let me give that one to Christina. She's smiling. She's the expert. There's a technical question there. If anybody else would like to come in on the technical question, just raise your hand. But that one's for Christina.
What I can say is that, okay, I don't have the figures at the top of my head right now, but based on the onset of infection, one can easily predict or think what are the likely causes of infection in this baby. For example, if the infection is early onset, meaning that it's within the first 72 hours of life to the first week of life, then most of the organisms that have been shown to cause infection in these babies are gram-negative bacteria in our setting, as opposed to other gram-positives such as B streptococcus in developed countries. And then for late onset sepsis and also community-acquired infections, we have a mix of gram-positive and gram-negative organisms causing infection in neonates. Thank you.
Thank you. There's a question here about when will the observational study, when will we have the readout, and will there be information on outcomes? Christina, and then perhaps if Manika's on the line, Manika would like to come in on that one too.
Thanks for the question. So for the observational study, we completed recruitment and follow-up of the babies in February this year. And we are currently working on completing data cleaning, and the completion of this is planned to happen at the end of this month. And then from there, we'll have the other activities that are going to go towards preparation of the results. So hopefully we are aiming towards having the results available towards the end of this year, early next year, but Manika can comment on that further.
Yeah. Manika, please join the conversation.
Yeah, sorry, this is Manika here. Yeah, so I can confirm that we would expect to have the data from the fosfomycin study in the last quarter of this year, and probably the first quarter of the next year for the observational study. But there's quite a lot of data that's been collected from there, and I think it's going to also take us a little bit of time to unpack the significance of that and how that will impact on our subsequent work. We are currently now evaluating how that is already impacting on the choices we may make on potential old antibiotics that we could repurpose and combine for use of infections. And obviously, you know, we have to make sure that we're not going to develop treatments that may be redundant in a short period of time. So that is one concern. And of course, on the flip side of the coin, as both Stefan and Hanan have pointed out, we are also trying to utilize the data to better understand how we can take a more integrated approach and work with other partners. So we're not taking a pure drug development kind of perspective. I think this has to be integrated into a much wider perspective of what has to be done. There is the issue of and challenges of how to deliver access, which Stefan has kind of run through. But there is also the wider issues of how do you appropriately place treatments in the context of guidelines, but also in the context of other interventions like IPC. because we don't want to actually make a situation worse, rather when we are introducing these new treatments. I would make a point that one of the major challenges is still that in general, the development of antimicrobials is a bit of a dead zone. It's not seen as a commercially lucrative area, and for the public and private sector actors who are working in this space, there are very limited resources and very few incentives, even though things may change hopefully in the near future. I don't think they will sufficiently change overall, but particularly then when you look at a subset of that for neonates and pediatrics, we are really in trouble. And I think there's a real lag between development of new drugs and then development of drugs for neonates and pediatrics. We haven't even done that for the old drugs properly. So we have a lot of catching up to do.
Thank you, Manika. And there's a question here about, are there any interventional trials designed or done in educating, counselling parents about neonatal sepsis and the importance of hygiene to reduce the chance of neonatal sepsis, especially in low and middle income countries? Stefan, if you would like to pick up the question if Manika has briefly lost connectivity.
Well, I'm personally aware about cord care and interventions, for instance, and educating parents about how to take care of the cord and using disinfectants, etc., and not putting harmful substances on the cord. So that's sort of one of the examples. To my knowledge, in the hospital and clinic delivery setting, you have a much more disempowered patient. So I'm not aware of any trials targeting patients and parents in that setting. I think that's the domain of health workers to actually provide good quality care. So there, it's the health worker you need to target, and more than the health worker, the whole infrastructure and the hospital director and all of those things, because the individual health worker should also not be penalized for not having running water, for instance. On the other hand, the individual healthcare worker obviously has a big role to play in hand hygiene and how you move between patients, etc. So it is a complex system.
Hanan, please.
Thank you very much. I think that's an excellent question, to be honest with you, because we didn't touch much on behavioral change, whether it's among the healthcare workers or among the families and parents. And I think each culture has their own specifics about how they deal with their patients and how do they mingle and how do they, care for especially the neonates and each other. So at WHO in the AMR division, we're trying to expand the entities of research, and implementation research is one of our bigger priorities. And we're trying to understand what interventions work best to to deflect on the surgence of antimicrobial resistance. And I think these types of research are very difficult to do, and again, some of them can really not be fully generalized. I want to catch up on the hand hygiene example, which has been with us for over 15 years, or maybe even if you want to count back to Semmelweis, then quite a long time. But if we still look at and that was core to my work back home, we still see, even in the international data, healthcare workers are really not doing a good job with hand hygiene. And when you look at the simple 5 moments, what scares me sometimes is that you see the rates of compliance even after. So one of the 5 moments is after exposure to body fluids. You would expect at least that time to be, or that moment to be 100%. But even then, it is, it could be between 60 and 70%. So we have a long way to go about how to change behavior and to introduce these precautionary measures as core to our interventions. Thank you.
Hanan, just to come to you with a question, and then there's some forward-looking questions I'll put to Manika before we close. There's a question there for you, Hanan, which says, we're hoping to get updated guidelines for neonatal sepsis. How are we doing from a surveillance aspect, especially in low and middle income countries, to inform the development of updated guidelines?
Excellent question. I expected something on that. We launched our third report on GLASS, which is the Global Antimicrobial Surveillance Program. And we're happy that we're very humble about where we're at with GLASS. We're in our third year, and it's what we would call version 1.0. It's really based on collecting information and data susceptibility patterns from countries. And from the first launch in 2017 till today, we had 22 countries, and today we have 99 countries as part of this project. And I think it has one condition for joining the GLASS, is that the country has to be willing to work with us on the lab capacity building. And to me, that is extremely crucial. Before we want to get data, we want to make sure that the country can stand on their feet by being able to do susceptibility, sensitivity, and do bacteriology basic work in the country. And then they need to have national surveillance programs. Then we share it with the globe. But I'm very keen on what we're doing in this specific country. Now, version 2.0 for GLASS, which we're hoping to do soon, within the next maybe 18 months, hopefully less, is that we want to be able to not look at antimicrobial resistance only from the lab perspective, but to have a face for every pathogen. That way we will be able to collect more useful data for the countries and to be able to do better global estimates based on the enrollment into GLASS. So having at least the basic demographics to start with about the patient linked to those specific pathogens. And that will answer the previous person's question to give a better global burden about, are they ESBLs, are they CREs, but also are they gram positives versus gram negatives, and which ones are they? So we have a long way to go with that, and I think it is, in my opinion, one of the big entities that needs to stand strong for us to tackle AMR.
Thank you very, very much, Hannon, for that comprehensive answer. Manika, one for you. Of course, we've heard that you said there hasn't been so much commercial incentive for the pharma companies, and that's where you're struggling. Here, the question is, does GARDP look for preferable, reliable partners for new studies with production sites in the EU?
So that's a good question, and we have two challenges that Stefan alluded to. One is, of course, we are looking for partners who have, I would say, new chemical entities of interest, and that we can partner with them to co-develop them, accelerate the development for children and neonates. And we need to do this because, as has just been mentioned by Hanan and Christina, things are evolving on the ground level, and we need to be prepared and have a better armamentarium of the new antibiotics as well as old antibiotics, and know how to use them appropriately and have the right guidelines, which will require both regulatory and I would say public health trials. But we also need to have a viable and secure supply of these antimicrobials, and including adapted for both for the pediatric and neonatal formulation. So there might be some important differences here in that. And so we do need committed partners who will be willing to invest long-term in this, in both, I think from different regions of the world. I think Stefan is absolutely correct. We need to take into account more, I would say, resilience into the system, so to speak, that we can take into account in the future, bearing in mind that there will be other issues, whether they're health security related or not. There will be other issues in the future. And this could be geopolitical, who knows? But that we cannot really continue working like we did before. And we were having problems with even supply of old antibiotics in the recent past, and we cannot go back to this now. So indeed, I would say the answer is yes. But there, I think, we need some action, not only from the private sector partners, I think particularly from the bigger companies who can and should step up and make these commitments. But I also think governments also need to recognize that they need to put in place a better system of incentives to guarantee a more sustainable economic system for this, if I can say it that way.
Thank you, Manika. As we are now at 3 o'clock, I'm just going to ask Stefan for some very brief comments on that before we close this webinar.
No, I think it's, as Manika alluded to, doing a systems analysis and a systems fix to get functioning markets for the existing antibiotics and new antibiotics, I think we've sort of played with in the old high stakes, high risk, but sort of economic efficiency league for too long. We need to actually emphasize security. So UNICEF, through our supply division, works a lot on pool procurement and market shaping and trying to shape functioning markets. And I think it's important that any new substance enter with such functioning markets in mind. And I know it might be easier because GARDP is not looking to get rich on this drug here, but nevertheless, it's worth thinking about very much from the outset. And UNICEF would be a keen partner in doing that. Thank you.
Thank you very much, Stefan, and thank you, your audience, for your great questions. There are a few others. There's a very broad one, which is, does GARDP plan any new studies, which I'm sure they'd be delighted to tell you about, most probably in another webinar. So as time is not our friend, I'm going to say thank you very, very much to Dr. Hanan Balkri, Assistant Director General of the WHO for antimicrobial resistance, Dr. Cristina Obiero, who is the co-investigator of the fosfomycin trial and also involved in the observational studies. We're waiting with great impatience to get those results. Thank you very much, Stefan Pettersson, who's the Chief of Health from UNICEF, and of course, Manika, the Executive Director of GARDP. And just to say that there are some webinar recordings that you can find on the website, or they'll be put shortly on the YouTube channel. And if you would like to know more about what GARDP is up to, there are other webinars, as you can see, on the 30th of June and the 9th of July. This is obviously a very important topic. I think perhaps COVID and the fact that we weren't ready for COVID has made everybody aware that we need to be ready for antibiotic resistance and AMR. The next pandemic, I read in an article that Hanan was quoted on, is already with us. So much more needs to be done on this issue. Thank you so much, everybody, for joining us from around the world. And I do hope you'll join GARDP for their other webinars on this very important subject. Thank you.
Thank you. Goodbye.
Thank you.